So now we will be discussing about aortic dissection. This is a very important case scenario that one needs to know. There have been many questions in e-medicine, and also there are many recall questions from these. So see, any patient who has a chest pain, we always think of MI. But after watching this lecture, you should also consider aortic dissection as a good differential for this. So let's proceed now. So what happens is, for example, if this is our aorta, in the aorta, the wall, there are 3 layers. So in one of the layers inside, there is a tear. Okay, so if this was a normal wall, and then there becomes a tear. Now this tear can extend proximally or distally and produce such kind of symptoms. So what is the cause that is causing such kind of tear in the aorta? So when there is high stress on the wall, what that can be? It is due to chronic hypertension. It can be due to smoking or atherosclerosis. Plus, if the walls of the aorta are weak, why will they be weak? Because of some connective tissue disorder like vasculitis, Ehlers-Danlos syndrome or Marfan syndrome. So in such situations, the tear occurs and the blood flows. So how will a patient present? So the patient is definitely an unstable patient, and he'll come to an emergency department and there will be a ripping chest pain. It's not a normal chest pain. It's a very sharp ripping chest pain that a person experiences, and this chest pain also radiates to back. Okay, so this is important. This chest pain radiates to back, unlike the pain of MI, which radiates to shoulder or jaw. Okay, this radiates to back. So what kind of symptoms can be there? If you look at this aorta, in this case, see, if there is something problem with this, if there is no blood supply through this, it can lead to decreased blood to the brain. That will lead to stroke or TIA. And here as well, because the carotid arteries, they make the circle of Willis and that supplies the brain. So if there is no blood flow through these, it can lead to stroke or TIA. And a very interesting finding, which is very specific to aortic dissection, is that see, when you measure the BP of a right arm and of a BP of a left arm, ideally both BP should be in a normal range, that they should match with each other. But what happens in aortic dissection is that there is more than 20 mm difference of BP in both arms. So in the right arm, the BP will be lower, and in the left arm, the BP will be higher. So let's say if the BP here is 180 and 100, in this case, it is going to be 230 by 130, right? So there is a difference of more than 20 mm. Then we consider aortic dissection as a differential. And if the descending aorta gets affected, we will have decreased blood to our bowel, and that can lead to mesenteric ischemia. Decreased blood to kidneys, that can lead to AKI. Decreased blood to limbs, that can lead to acute limb ischemia. And if there is decreased blood through the right coronary arteries as they supply our heart, then that can lead to MI also. And there is also an artery which supplies the aortic valve. Okay, so if that is also affected, that can lead to aortic regurgitation, which is a diastolic murmur. So let's just take a look at the clinical features again. So depending upon what arteries are affected, it can lead to stroke. There is a difference of BP in both the arms. There is AKI, mesenteric ischemia, acute limb ischemia, diastolic murmur due to aortic regurgitation, and MI can be there. And there is a ripping chest pain that radiates to back. So now once you have made the diagnosis, obviously in the body, there is going to be decreased blood supply, and it leads to a shock like situation. The BP is going to be 90, 60, and such patients are unstable always. Okay, and let's see how we will proceed with this. So after we have suspected aortic dissection, we do chest x-ray. The chest x-ray findings can be, there will be a widened mediastinum. Okay, because of the tear, the blood has been extended. There will be irregular aortic contour, and there will be hemothorax. There will be blood in the thorax. Okay, so these findings are present in case of the aortic dissection. So anywhere when you see widened mediastinum, always think of aortic dissection first, and although there are many other differentials for these as well. So how will you investigate such patient? So now let's just see that there is a hypertensive patient. He comes to ED with a chest pain and then you checked the BP on the right arm comes to be X and BP on the left arm comes to be Y, and there is 20 mm difference between both the BPs. So now you have aortic dissection. So how are you going to investigate such a patient? See, if the patient is unstable, you have to perform an investigation which is quicker and bedside, that is TEE. But if the patient is stable, you can shift the patient to a good investigation. Then you do a CT aortography, where we put a contrast and we can take a look at what part of the aorta is affected. So after you have diagnosed this, what you do is you manage such patients. See, if our patient is unstable, okay, so obviously if there is a patient who's unstable, either the patient's BP is going to be too high or the patient's BP is going to be very low. There can be both scenarios, although this one is more common. So if there is low BP, you give the patient vasopressors or IV fluids. If the BP is very high, what you do is you go for beta blockers, and after the heart rate is under a little control, you go for vasodilators. You can't give vasodilators first and then give beta blockers, because if you give vasodilators, that is going to lead to reflex tachycardia and you're going to put the patient in arrhythmias. So always beta blockers first and then vasodilators. But if the BP is low, you have to go for vasopressors and then IV fluids. So we need to control our BP. This is our main thing. We need to control, because if the BP is very large, that is more than 120 by 80, it is going to extend the aortic dissection due to more stress on the aortic wall. So we control the BP at less than 120/80 and pulse rate at less than 60. Coming at the definitive management, after we have controlled our BP, now we have to proceed with some kind of surgery. Okay, so see, there are two types of aortic dissection. It can be Stanford A or it can be Stanford B. How I remember is Stanford A means that it is proximal to brachiocephalic trunk. That means it is present in the ascending aorta. Okay, and the B, it is B for beyond. It is beyond the brachiocephalic trunk. Okay, so this is proximal to that and this is beyond that. And in cases of Stanford A, we definitely need emergency immediate surgery. We cannot think whether we need to go for surgery or not. We have to go for immediate surgery, and that too open surgery or endovascular if the patient is unfit. But definitely we need to go for surgery. But in case of Stanford B, we only do surgeries if there are three conditions. Number one, if the aorta size is more than 5.5 centimeter, if there is no improvement with conservative management, or if there are some end organ complications. Okay, so now we have completely learned how aortic dissection patient will present and how will you manage. Acute treatment is controlling the vitals, and after that, based on the Stanford classification, you have to go for whether we are going to perform surgery, and in case of Stanford B, we'll look at the indications if surgery is needed. And I'll just discuss another small case, and this is about the rupture of thoracic aorta. So as you can see that there is something weird going on in this X-ray. This is also a widened mediastinum, and this is an X-ray of thoracic aorta rupture. See, one cause we have already discussed, that it can be due to aortic dissection, but other causes are also there in cases where thoracic aorta can rupture. This is when there is blunt trauma to chest. Okay, so if you see that the patient had an accident and he's presenting with such situations similar to aortic dissection, it is because the aorta has ruptured. What happens is that there are direct shearing forces of the vertebrae, and see, what happens is that when you rapidly decelerate your car, the ascending aorta and the heart, it goes in one direction, and the descending aorta goes in the other direction. So at this position, it gets ruptured. So this is the case that I wanted to discuss, and rest, this is all about aortic dissection.